And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done at this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis. This is the investigations required. This is the likely treatment. And then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken. You will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases, in which a lot of interactive discussion.
That yearly review for thyroid, actually it is a very big topic. So what I have tried to concise that what are the various avenues where we are going to act upon? What are the various thought process that in coming years probably still they are unsolved puzzle? Probably we are going to get answer for the same. And what I have divided in two parts, that is particularly that is in neonatal or say congenital hypothyroidism. What new? And the second, that is thyroid excess, that is thyrotoxicosis, Graves' disease. What are the newer armamentarium? Just I'm going to talk about that. First, that it is really very important that we do correlate that mental retardation or neurodevelopmental delay with maternal level of thyroid and iodine. So, is there really association between maternal urinary iodine assessment, dietary iodine intake, neurodevelopmental outcome in the child? And this was a very important systemic review I came across, and they have done with the. So what they have concluded after so many searches, and the net conclusion that the majority of the studies classified pregnant women to be mild to moderately iodine deficient based on urinary iodine assessment with subsequent offspring neurodevelopmental implication, whether this is there or not. So what this review suggests that dietary intake data may indicate a stronger association with cognitive outcome than urinary iodine measurement alone. So it means that we have again back to basic, that we have created a good history in terms of even what is the intake. So what is the strength of this review? That it distinguishes results based on cognitive outcome per urinary assessment with dietary data. So still, this is not a very robust, so we can't say that yes, it is, but yes, it sensitizes us that future work is needed respecting the usefulness of urinary iodine assessment as an indicator of deficiency, whilst also taking account of dietary intakes. Now, second is that one more thing, that it is not easy to manage Hashimoto thyroiditis, and is there any new or some additional drugs you can add for better management of Hashimoto thyroiditis? So this is a very common autoimmune disease characterized by high level of thyroid peroxidase antibodies and thyroglobulin antibodies, as well as infiltration of lymphocyte in thyroid. So that's why you are going to have a formed thyroid during palpation. In recent year, metformin is not only, you can say that ये diabetes की drug नहीं है, it is having so many implications. So what they have proven that effective in a variety of autoimmune disease, that is SLE, rheumatoid arthritis, multiple sclerosis too. So what in this study systematically explored the therapeutic effect of metformin on Hashimoto's thyroiditis and its underlying mechanism, that how it is going to help. And they have done a very robust study. They have used animal model, in vitro, cell culture, differentiation, mRNA sequencing, and what they found that metformin indeed had a therapeutic effect on mice with this Hashimoto's thyroiditis, mainly by reducing thyroglobulin antibody and lymphocytic infiltration in thyroid tissue. In addition, metformin also significantly suppressed the number and function of T17 cells and macrophages polarization. One more thing, that how it is going to act. So mainly they have postulated that it is going to act on by regulating immune pathway. The third, a very important, interesting, that people are consuming so many things. We are doing day in and day out these thyroid function tests, and thanks to wellness checkup, that is annual checkup, जो अभी package में आता है वो from various pathologists. So what they have tried to do that, well, what are the effects of micronutrients on thyroid parameters? So micronutrients are involved in various vital cellular metabolic process, including thyroid hormone metabolism. So correlation between serum level of micronutrients and their effect on thyroid parameters. So they have seen all the thyroid markers, and what they have found that deficiency of vitamin B2, B12, B9, and 25-hydroxy vitamin D is significantly affecting the thyroid functioning. One more important that amino acid, that is asparagine and serine, were found to have a strong positive correlation with TSH. Yes. So it is really important. One more study I came across that we very frequently use this, rather this is the first line of management if we are going to manage a case of thyrotoxicosis. So what's new? And why I have put this, that first we have to understand that what is the difference between a young patient presenting with Graves' disease versus late presentation of Graves' disease. So younger the patient tend to have more severe hyperthyroidism at presentation when compared to adults. And this is may be partly related to the nature of the underlying immune dysfunction. Why this study? That at least we have to prognosticate that how this patient or this big chunk of patients are going to respond with this simple drug or some more medication or some other modalities of treatment may be required later on. So recent data have shown that HLA complex 5, T5 polymorphism is independently associated with Graves' disease susceptibility and age of onset. So it means that we don't have to only work out for the thyroid function, but to predict that how this child is going to be in future management, probably we have to take the help of our geneticist also. This is a very beautiful paper what I came across, that randomized trial of block and replacement versus dose titration thionamide in young people with thyroiditis. A very long debatable topic. कौन सा ठीक है कौन सा नहीं ठीक है, इसका कॉस्ट इफेक्टिवनेस किसका कॉस्ट इफेक्टिवनेस नहीं है. So keeping in mind that what we expect as endocrinologists, so we thought that, or the people thought that, expectation was that biochemical control might be better with individuals on block and replacement therapy, which was not observed with this paper. So while the study was underpowered, the likelihood of beneficial effect of block and replacement on biochemical control being overlooked because of this was remote, and there were more adverse events in block and replacement group. So I'll show the figure in next slide, that what is the distribution of TSH in patient from trial. And what it's shown that no meaningful improvement in biochemical control on block and replacement therapy in most patients. So you can see here that randomized trial of block and replacement versus titration. So proportion of TSH value within normal range. So it shows that no significant difference. And of course, if we are going to restrict with titration therapy, probability of lesser side effect in comparison with block and replacement therapy. But again, this is not the whole story. So what next? Here you can see with the same corollary that severe Graves' disease ultimately resulted in a change from daily to this high dose regime, comprising a larger dosage of carbimazole as a part of this block and replacement regime. So this is the caveat that once the disease is severe, probably you are going to do the same, that you are going to increase the dose, and probability of this block and replacement therapy is there. But of course, As a general rule, probably we have to stick on titration regime, that is DT regime, is good. Now the third question is that going to stop. So if the patient is euthyroid at the end of 12 months, then the likelihood of relapse is small and thyroid status can be less frequent. What next? That if the patient is euthyroid 2 years after stopping anti-thyroid drug, then it is feasible to discharge the patient back to general practitioner, though blood still needs to be checked on annual basis, not only for recurrence, that is Graves' disease, but rather hypothyroidism. So that is really important to look upon. This paper, I really request all of you to go through this, that this is going to set up a number of things that so alternative strategies, what can be the alternative strategy? So one future area of research in this thyroid management is to focus in greater detail on patients with more severe disease who are less likely to respond to anti-thyroid drug in long term. So perhaps these patients may ultimately benefit from newer immunomodulatory strategy such as biologics, TSH receptor antibody and peptide therapy. So where they are going to act upon, so new therapeutic horizons for Graves' hypothyroidism, that is a group of drugs that is rituximab, which has been very frequently used in so many conditions. So how they are going to have to act, that is beta lymphocyte immunomodulation. That is one approach. The second approach can be the drugs which can, that is neonatal FC receptor blockade, and they are going to block immunoglobulin recycling. The third group, that is TSH receptor signaling drug, they are going to block this, and the fourth, that is immunomodulation, that is on the TSH receptor peptide, that is immunotolerance. So these are the future that how we are going to act upon. But still, with the available study and data, these drugs are not alone sufficient to have cure or remission for thyrotoxicosis. So, in nutshell, how we are going to, what is the future, that is relationship between what we have to again explore, that is relationship between autoimmune thyroid disorder duration beyond 5 years and likelihood of relapse needs to establish in greater detail. The baseline immune and genetic factor that may impact on likelihood of remission need to be explored in more detail. This may help to predict outcome. Patient can potentially be stratified as low or high risk of an adverse reaction to anti-thyroid drugs, including agranulocytosis, with associated alteration in surveillance program. The potential role of long-term iodine therapy needs to be explored in more detail. The role of existing and novel immunomodulatory agents still need to be explored. And long-term, this carbimazole therapy in excess of 3 years duration is still a realistic option for young patients with Graves' disease who are at high risk of relapse. Data from randomized trial indicates that this titration therapy is associated with similar biochemical control when compared to block and replacement therapy. Yes, one more thing, that what we expect in thyrotoxicosis, that अभी weight gain उसका ठीक होना चाहिए, but how weight gain can be a major problem in patient with Graves' disease starting this anti-thyroid treatment. Not only that this drug, but rather if these patients are going to have hypothyroidism, probably it is going to increase much. Patient in remission following anti-thyroid drug need monitoring because of the potential for autoimmune hypothyroidism as well as relapse. Because if you are going to test not thyrotoxicosis, not only the jab antibodies, but rather they are going to have infiltration and probably they are going to have positive antibody for anti-T2 and anti-thyroglobulin. So this patient, that is was, it was a patient of thyroid toxicosis. Later on, over a period of time, they can have a frank known case of hypothyroidism. So these are the literature what I have came across. So thank you so much.
It was a wonderful talk. Thank you.
Thank you. And these are the suggested reading and references. Thank you.
And we will share the references to the one you shared with me and share to everybody.
Yes, yes.
Wonderful.